Long QT syndrome was first clinically described in 1957, so we're actually now at the 50th anniversary since the first description of this, what we view and others view as a potentially lethal, highly treatable condition. One of the breakthroughs came in 1995, 14 years ago, when the genes that were responsible for this disease called long QT syndrome were discovered in Mark Keating's laboratory. That ushered in the decade of so-called research-based genetic testing from 1995 to 2004, where there were a handful of research laboratories throughout the world, like our laboratory here at Mayo Clinic, that was doing research genetic testing. This was a very frustrating decade, a very slow decade of time, slow to come, when this period has been affectionately or disaffectionately dubbed the black hole, the time and place where samples went and nothing returned. And then that gave way in 2004 to a commercially available clinical diagnostic test, which Mayo Clinic and my laboratory played a role in moving out of the research environment into a clinically available test. Since over the past 5 years now, physicians like myself and other cardiologists throughout North America have been able to order this diagnostic test and utilize it in the evaluation of patients with long QT syndrome, just like all the other diagnostic tools that we have, the 12-lead electrocardiogram, the treadmill stress test, and so forth. And one of the things that our laboratory has been very active in is helping us become wise users of the test and even wiser interpreters of the test. And this latest study is a helpful aid to tell us what exactly does the genetic test tell us and what does it not tell us in terms of the certainty as to whether we have found the so-called X that marks the spot, finding our patient's true long QT syndrome causative mutation. We did a multi-center study with a colleague of mine, Dr. Arthur Wilde in the Netherlands, as well as our collaborators at PGxHealth and the Familion long QT syndrome product line. And what we did is we compared cases of slam dunk clinical cases of long QT syndrome with the panel of rare variants found among almost 1,400 healthy volunteers. And we looked at what was the results of the genetic test results of genetic testing in both of those cohorts. Really good cases of disease and really bad cases of disease, in other words, healthy volunteers, so that we could learn from that and find out which rare variants are so-called just there, just rare, just because, and which rare variants actually rise to the level of a bona fide disease causative mutation for something that we call long QT syndrome. This involved almost 400 cases that we did the mutation spell checker on, compared to almost 1,400 healthy volunteers. And we learned several very important things. First, that there is in fact a background noise rate, if you will, of rare genetic variation that looks at one level like mutations. In fact, if we arbitrarily did genetic testing for this disease as a universal screen, that would be a colossal mistake, because about 4% of Caucasians and about 6% of non-Caucasians have rare genetic variants in these genes that cause the syndrome. Now that's compared to what we've known for quite some time, that if you have a great clinical case of the disease, we will have a positive genetic test result about 75% of the time. So if we think about testing in Caucasians, for real cases, we have a 75% yield. In really healthy volunteers, we have about a 3 to 4% chance of a positive test. That means that the test is just one piece of information, and it's proving what we've known in the genetic testing circle for quite some time, that genetic testing, whether it's the long QT syndrome genetic test or any of the over 1,500 genetic tests that are available to clinicians to order, these tests are not binary tests. Yes, no. Yes, no. These tests are probabilistic tests, where the variant of interest, the mutation, probably, maybe, is the disease mutation. And the probability of pathogenicity, if you will vary. And one of the things we learned critically with the long QT panel is actually two things. Besides there being a rare background noise rate, secondly, we learned that the mutation type mattered a lot. So there are certain kinds of perturbation, mutations, hits to the genes of interest that are almost slam dunk mutations. You can almost bet the ranch that that kind of mutation is deleterious. What does it mean to the patient that I'm going to see tomorrow for long QT syndrome? I think the message for the patients is progress has been made. Amazing progress has been made from the sentinel discovery in 1995 to the clinical availability of the test in 2004, and now in 2009 we are getting smarter and smarter about interpreting more accurately what the test means. So it's easy to now get the test, or I should say it's easier, it's simply a blood test. There has been tremendous improvements in insurance companies recognizing the clinical value of the test and having favorable reimbursement plans for the test. And so that now that physicians can incorporate this test more and more into their practice, and now that insurance companies have become more and more enlightened such that access to the test has not been hindered, we have to make sure that the state of the interpretation of the test, the ability to distinguish true disease mutations from truly noise, is really, really critical. And I think this is an important step in that, not just for long QT genetic testing, but really for genetic testing at large, where it tells us that there is a background noise rate for any of these genes that we're interested in, for any of these diseases for which mistakes in those genes cause that disease. And we have to make sure that we have our A game on to interpret. And that does mean for some patients that it's not just going to be enough to just get the test. The test has to be interpreted. And it has to be interpreted by individuals who know what they're doing, who know what the test can and cannot tell us, who understand the limitations of the test, who understand the so-called false positive rate in the test, and can put all the pieces of the diagnostic puzzle together. This is no different than any other test that we order in medicine, or any other test that I order in long QT syndrome specifically. I know all of the warts and the wrinkles that come with the ordinary 12-lead electrocardiogram that we order every day. And we see all of the mistakes that have been made with that diagnostic test. So one of the keys with genetic testing is to understand the warts and the wrinkles that come with this diagnostic test, so that we know what it tells, when it tells us the mutation, that we can realize that I can't just take it at face value. I've got to insert it and assemble it and have it test to see if it fits the entire storyline. Does it make sense? How confident am I that I have truly found the patient and their family's true culprit? Or where do I need to hit the pause button and say, it's another piece of data, but I need to get more evidence. And I need to strengthen the case by either doing additional studies, some of them perhaps might be research, or whether or not I'm satisfied with the level of the evidence, if you will, to pronounce a guilty verdict and say we have found the X that marks the spot for this individual.